Thank you all for joining and being here. And again, appreciate Dean Liu to be here and, take busy time from both his professional side as a public health person as well as a dean for the School of Public Health at Berkeley. It must be really taxing on you, but thank you so much for being here. Appreciate that. Today, in fact, I couldn't have imagined a better person to talk about this whole situation today, right? He's a trained doctor, he's a public health professional, and an educator. So all things rolled into one. It's absolutely fantastic to have him here. Before he starts his talk and speaks to all of you, let me just introduce him very briefly. I'll not take long. I know you're eager to hear from him, but let me nevertheless talk a little bit about Dr. Michael C. Liu. As I already mentioned, he is the current dean of the UC Berkeley School of Public Health and has deep-rooted passion for health equity and social justice. He has dedicated his research to the development of testing and translation of new theory of origins of maternal and child health disparities. I'm sure those of you who have joined from India would very easily relate to that. Michael has an MD, MS, MPH, and is a graduate of the UC Berkeley UCSF Joint Medical Program. Of course, has decades of expertise as professor of public health, as well as obstetrics and gynecology practitioner, a proven track record of academic and national executive leadership. Dr. Liu was formerly the Senior Associate Dean for Academic, Student, and Faculty Affairs at George Washington University's Milken Institute School of Public Health, where he led efforts to expand the undergraduate program, overhaul the MPH curriculum, strengthen doctoral training, institute a Master Teachers Academy, and improve the student experience. Prior to that, he was also the director of the Maternal and Child Health Bureau for the US Department of Health and Human Services for a considerable period of time from 2012 to 2017. During his tenure, Dr. Liu transformed key federal programs in maternal and child health, launched major initiatives to reduce maternal, child, and child mortality in the US, and was awarded the Herbert H. Humphrey Award for Service to America. With that, I'll let Dr. Liu take over and start.
Thank you so much, Dean Chatterjee. Good evening, everyone. I'm so honored to have this opportunity to talk with you. As Dean Chatterjee mentioned, I've been the dean at Berkeley since last July, and one of my big goals as a new dean is to expand Berkeley's global collaboration, recognizing that if we're going to solve these big global public health problems, we're not going to be able to do that by staying in our own little silos. So, in fact, I was actually planning to visit Shiv Nadar this month, but then the global pandemic happened. So it's literally been COVID-19 24/7 ever since. So I thought I'd spend the first part of my talk just talking about our COVID-19 response at the UC Berkeley School of Public Health. But I also wanted to take the long game. COVID-19 too shall pass. So I want to spend a little time today talking about my vision for the School of Public Health in the coming decade, and hopefully explore some opportunities with you for collaboration in the post-COVID world. But let me just start with the COVID-19 response. And first of all, just my thoughts with all the families and friends of the more than 300,000 people who have lost their lives to COVID-19, the millions who have taken ill or lost their jobs, the billions whose lives have been upended by the pandemic and its economic fallout. But at the same time, I've never been prouder or more grateful than to be a part of this amazingly caring and resilient community that I'm now the dean. Many of my faculty, students, and staff have answered the call to action in research, in education, and in practice. In research, my faculty are working day and night at the leading edge of COVID-19 research, from doing basic science research elucidating the molecular mechanisms of SARS-CoV-2 to conducting translational research working on the development of developing rapid diagnostics and novel therapeutics, to conducting population-based research looking at statistics modeling, asymptomatic spread, and health inequities. In education, we had to move about 100 classes to remote instruction in about 48 hours back in March. Our faculty, students, I think really did their best, but it hasn't been without challenges. And we don't quite know right now what's going to happen to instruction in fall. We're asked to do scenario planning for 3 scenarios: completely remote instruction, a hybrid of remote instruction and in-person instruction, or a third scenario, which is mostly in-person instruction. Seems pretty unlikely to many of us, especially as many public health professionals like myself worry that many parts of the country, many parts of this the state are reopening too early, which could lead to another surge in the fall, or just waves as the epidemic curve would likely evolve. So again, we don't know what's going to happen to the instruction in the fall, but regardless of modality, I think our commitments to be able to deliver the highest quality education to our students that our students at UC Berkeley have come to expect. And in fact, many of my faculty see this crisis as an opportunity to truly innovate, disrupt, and transform our education, being able to leverage the latest educational neuroscience and pedagogical and technological innovations to take our education to the next level. So for example, the use of flipped classroom, where students watch asynchronous pre-recorded lectures on their own, and then spending synchronous classroom times, and whether that's going to be online or in person come this fall, with some proper social distancing, doing group projects, discussing case studies, or getting individualized help. And then in practice, many of our faculty, students, and staff have really stepped up, providing public health leadership at a time of public health crisis. We're the only school of public health in the San Francisco Bay Area, and so we've been working really hard to address the public health needs of our Bay Area communities. Our faculty, students, staff have organized PPE drives and food drives, blood drives, other relief efforts. They've done more than 150 interviews, op-eds, commentaries in the New York Times, Washington Post, CNN, and then nearly a dozen public events with more than 100,000 views on Facebook to educate the public, at the same time to really elevate the voice and visibility of public health, including calling out structural iniquities and racism which underlie much of the health disparities related to COVID-19, with African Americans accounting for more than 70% of COVID-19 deaths in places like Chicago and Louisiana. And lastly, we're also working with our chancellor, with our campus leadership to help the campus reopen safely. But the big question that I think you're probably thinking about, we're certainly thinking about it, many campuses around the US are wrestling with this big question, is how do we bring students, faculty, staff back to campus safely? And for us at Berkeley, that means bringing 45,000 students and 15,000 faculty and staff back safely. How do we assure parents of our students who are asking the very important question, is it safe for me to send my son and daughter back to Berkeley in the fall? So here's what we're currently thinking about. I think for campus to reopen safely, 4 conditions have to be met. First is universal testing. And we all been in shelter in place for the last couple months now. If everyone had truly stayed in shelter in place, conceivably the virus could be kind of burning itself out. But then kind of once you reopen the campus to students coming back from different parts of the country and different parts of the world, there's the possibility, the real possibility of kind of reintroducing kind of reinfection into the community. So the idea is that we really need to have a system in place for universal testing, so that we're able to quickly identify and isolate those individuals, those students with an active infection, especially those with a pre-symptomatic or asymptomatic infection, which has made COVID-19 so hard to contain. The second condition is to have a system in place for infection control. And that includes many of the public health measures that we know, which require both behavioral as well as environmental modifications to maintain social distancing. The third condition that has to be met is a system in place for rapid response. To be able to test, isolate, and contact trace quickly. And then the fourth is to have a system in place for ongoing surveillance for outbreaks. This requires kind of both syndromic as well as behavioral monitoring, the use of technology, apps, GPS-enabled apps for location tracking, as well as environmental tracking. So, for example, testing sewage, water, or air filters, and then some ability to conduct testing. Now, we could be doing random testing, but that would be kind of like looking for a needle in a haystack. Or we could be testing everyone or almost everyone every month, which our campuses like UC San Diego is proposing to do, and they have about 60,000 students that they would be doing that every month. I actually think that a smarter way to do this would be to kind of leverage machine learning to sift through these kind of different data streams from syndromic monitoring, location tracking, environmental monitoring, and testing to help us identify geographic hotspots to target testing and to be able to predict and prevent an outbreak. And also kind of recognizing that the campus is not an island. And if you ever visit the Berkeley campus, you know that there's actually no wall that encloses the campus. So an infected student can go to an apartment or to a restaurant and infect 50 other people. So what we're doing is we're also trying to build an integrated surveillance system with both City of Berkeley as well as Alameda County. And instead of testing the system on 45,000 students and 15,000 faculty and staff when they come back to campus, this summer, over the next few months, we're going to pilot on a smaller cohort of a few thousand students, faculty, and staff, try to learn as much as we can, work out all the kinks so that we can reopen the campus safely. I guess this kind of leads to the second part of my talk, which is, and really kind of the big question for all of us is, what kind of post-COVID world are we working toward? Do we try to get back to normality, and there's this kind of rush to try to get back to normality? Or can we reimagine a new world? Do we continue down the inexorable path to climate catastrophe, or can we light the way to new climate solutions? Do we continue the relentless destruction of natural habitats and harvesting the wildlife, which will keep fueling the risks for future pandemics? Or do we say enough is enough? Do we continue to keep trying to improve population health with a broken healthcare system? Or do we fix that system, but also tackle social inequities, address social determinants, ensure the social conditions in which everyone can be healthy, which is the true definition of public health? And do we continue to let hatred and bigotry and tribalism and nationalism divide us? Or can we get our act together as a world and mobilize an unprecedented level of global cooperation to tackle our greatest existential threats before it's too late? I really believe that we're at a pivotal moment in the history of public health, And I can think of nothing more consequential than what together we're going to do in public health in the coming decade. Now, if you think some of the biggest problems that's facing the world today, you think some of the greatest existential threats to humanity in the 21st century, from climate change to pandemic outbreaks, from chronic diseases to social inequality, these are all problems that require public health to be front and center in driving solutions. So when I arrived at Berkeley in July last year, I did a pretty broad listening tour, talked to my faculty, my students, our alums, and our staff, as well as other deans and many of the friends of the school in many parts of the country, really trying to figure out like what is it that I'm trying to accomplish in the next decade. And the reason that I say in the next decade, because at Berkeley, deans are appointed for 2 terms of 5 years each. So what is it that I want to accomplish in the next 10 years? So as the dean of one of the best schools of public health in the world, I decided that we weren't going to sit on the sideline anymore. That in the coming decade, we're going to roll up our sleeves and we're going to go all in, and we're going to tackle 4 of the most pressing public health problems of our time: climate change, pandemic outbreaks, chronic diseases, and social inequality. And the reason that we picked these 4, not only because they pose some of the greatest existential threats, but they also represent areas of some of our greatest strengths, as well as greatest opportunity to have game-changing impact. So for example, in climate change, it's about air pollution that we have a faculty that's world-renowned for their research and policy on air pollution, which is a major driver of greenhouse emissions and chronic diseases. In pandemic outbreaks, it's translating molecular discoveries to population-level impact. So for example, the use of CRISPR to genetically modify mosquitoes to stop the spread of malaria and Zika. In chronic diseases, it's all about innovation, driving innovations in food systems and health technology and data science. For example, the use of sensors and wearables, AI and machine learning to disrupt, innovate, and transform how we prevent and manage chronic diseases. And in social inequality, early childhood, and that's the background that I bring, to tackle social inequality at its developmental origins in early childhood. But honestly, if we're going to stand a chance against these 4 existential threats, it cannot be business as usual in public health. The fact that we've been fighting such a losing battle on so many fronts, the fact that as a field we're punching far below our weight, doing more of the same isn't going to get us very far. And that's why I believe that if we're going to change the world, we're going to have to change public health. We're going to have to disrupt, innovate, and transform how we do our work in public health, in research, in education, in practice, and in policy. And that's really my vision for Berkeley Public Health in the coming decade. So in research, in the coming decade, I want to help Berkeley become the innovation hub of the world in public health. I want Berkeley to be known as the place where some of the most groundbreaking discoveries and some of the most game-changing solutions in public health come from. But how do we become that innovation hub? Well, first by investing in human capital, by attracting the best and the brightest, the biggest thinker, the disruptive innovators, people who are going to come up with the groundbreaking discoveries and game-changing solutions from all over the world, focused on tackling those 4 great public health challenges of our time. Second, by catalyzing transdisciplinary collaboration and recognizing that we're never going to solve these big global problems by working in our little silos, working through our research centers, institutes, and clusters, leveraging the brilliant minds that we have across campus with some of the best schools of engineering and data science, biology and chemistry, natural resources, and public policy, as well as our strategic location in the Silicon Valley in California, and really across the Pacific Rim, truly innovation, that the innovation hub of the world to find solutions to some of the most pressing public health problems in our time. And this really reflects my belief that in 21st century, the game-changing solutions really need not to be bound by institutional, disciplinary, or even national boundaries. It's this kind of cognitive diversity, it's this kind of transdisciplinary collaboration that are truly the driver of disruptive innovations in the 21st century. And third, by building an innovation ecosystem, the first of its kind in public health in the US. So I spent the last few months learning about different models of innovation hubs to try to incubate, accelerate, scale, and finance breakthrough innovations in public health. In education in the coming decade, I want Berkeley to become known as the school for change makers in public health. So you probably heard that Stanford has a D school, D for design thinking. So I want our school to become the first C school of public health, C for change making, preparing the next generation of change makers in public health. Now why change making? It's really because the vast majority of the students who go into public health, especially the vast majority of students who come to Berkeley, they come here because they want to change the world. They want to make the world a better place. But the vast majority of faculty in most schools of public health get promoted for their research. And research is certainly a very important tool for changing the world. That's not the only tool. So my goal is that by the time that our students graduate, each and every one of them will be equipped with the knowledge, the tools, the skills, and experience they need to go out and make the biggest difference that they can, which will require three things. First is a change makers curriculum, which include not only the new C competencies like leadership, management, communication, collaboration, policy, and advocacy, but also competencies around philanthropy and fundraising, community engagement and organizing and mobilizing, and innovation and design thinking. Second is a change maker in faculty, which means expanding our faculty to bring in public health leaders who have not only studied public health, but who have led public health, who changed public health. And there is a change makers experience, which means expanding opportunities for our undergraduate and graduate students to have internships and field experiences so that they can put into practice what they're learning in the classroom locally and globally. In practice and policy in the coming decade, I want us to become a global leader in advancing health equity. So when people think about health equity in the coming decade, I want them to think of Berkeley Public Health, which is not going to happen if we just stay in our ivory tower. So first, we have to expand our community engagement, again, locally and globally. Going out into the community, working with the community, making a difference in the community, building radical collaboration with the community. Now, many of you have heard of the idea of social determinants of health. The idea that your health has more to do with the air that you breathe, the water you drink, the food that you eat, and the social conditions in which you work, live, grow up, and grow old, than it does with your biology or behavior. Well, Berkeley was the birthplace of the idea of social determinants of health with the work of Len Simon and Sir Michael Marmot. And many of you have heard the idea of community-based participatory research, the idea that when you do research, you do it with the community and not on the community. And Berkeley was the birthplace of CVPR with the work of Mary Minkler. So how do we take these powerful ideas to the next level? How do we continue to champion health equity here at home and around the globe through radical community collaboration? Second is to support public health practice change. So for example, I see all around in the Bay Area and Silicon Valley how advances in health technologies and data science are already transforming healthcare. But these advances haven't really gone down into the level of community health centers, public health clinics, safety net providers taking care of some of our most vulnerable populations, which proves the observation that technology and innovations by themselves don't always advance health equity. In fact, they can actually widen health disparities if there's differential access. So again, my goal over the next few years to help bring these safety net providers, whether it's La Clínica de la Raza, the Asian Health Services, the Alameda and Contra Costa County health departments into the 21st century by advancing open access data commons, open access softwares, making sure that no matter where you work in the world, whether you work in the community health center in Baltimore or Village Clinic in Bangladesh, you will have access to 21st century tools to solve 21st century public health problems. And lastly is to provide policy leadership, that as much as we like to think that we can solve all public health problems with public health programs and services, advancing health equity will require real political and social change. It will require us to go upstream. So for example, in maternal and child health, where I've worked for the last 25 years and was the head of maternal and child health for the nation under the Obama administration, that let's not forget that the biggest gain in maternal and child health in the United States over the last 150 years came from the promotion of hygiene and sanitation, child labor laws and women's suffrage, and the overall improvement in educational attainment, economic opportunities, and social status of girls and women in our society and around the world, and that the biggest gain in maternal and child health in the next 150 years will come from reversing global warming, cleaning up toxic waste sites, rebuilding our nation and the world's infrastructure, protecting reproductive rights, reducing social inequality, and ensuring the social conditions in which all children and families can be healthy and thriving, and that every child, no matter where they're born, or the family they come from, or the color of their skin, will have a fair shot at reaching their fullest potential. So let me just close with this one last thought, which is that I have 2 teenage daughters, and so as teenagers, they've now perfected the art of giving their dad a guilt trip. And their latest thing would be that the older one, Sasha, who's now 17, would say something like, well, Dad, now that you're Dean of Public Health at Berkeley, if there are things that you could do today which could prevent the kind of mess that we're gonna have to clean up for you 10 years from now, why didn't you? And then her little sister, Avery, would then chime in and say, yeah, Dad, why didn't you? So I really like to be able to tell them 10 years from now that, yes, we did. That me and my friends at Berkeley, and me and my friends from around the world, including hopefully some new friends from Shiv, Nadar, that we decided that we weren't just gonna sit on the sideline anymore. That we were gonna roll up our sleeves and we were gonna do something about it. So we went all in, we got to work, and together we made the world a better place for them and for their children. So that's my vision for Berkeley Public Health in the post-COVID world, and I certainly hope that we can find ways to collaborate with you all. So thank you very much.
Thank you so much, and I also hope that we could all collectively say, yes, we did it, and let's hope that it comes true for the sake of our children and the next generations. So there are questions already coming in, but before I jump into some of the questions which has already come, but let me just ask you a few things. So you have been, for a long time talking about disparity in public health and basically healthcare system and so on, right? And of course, Berkeley is known also to be dealing with and working for a broad-based society and so on. Do you see this COVID as a kind of a setback in some ways, where you think the health disparities will increase in many of these, in US and UK, we are seeing racial disparity, but also across countries you have talked about, for example, in Bangladesh, so Bangladesh versus US and so on, because the kind of resources that these developing countries will need to deal with COVID. In India, for example, we are seeing a real setback in dealing with tuberculosis, right? So do you see that COVID as kind of a setback in that goal in achieving much higher level of equity, health equity across races, groups, nations all across it?
Yeah, certainly. I'd see COVID really exposes the kind of structural iniquities that underlie much of our health disparities, and with the economic fallout that comes from COVID-19, I think those structural iniquities are likely to worsen. And this is not just in terms of access to healthcare resources, but in terms of economic opportunities, in terms of many of the structural iniquities, I think would be worsened by COVID-19. that said, I think I'm hoping that COVID-19 would also be a reset, a wake-up call to the world that what's going on is not sustainable, and that whether we try to try to like rush back to normality, or whether this provides as an opportunity to like reimagine what the new world should look like. So there's been a lot of discussion, for example, in the U.S. about how do we use COVID-19 as an opportunity to rethink about our healthcare system, and can we better leverage technology like telehealth to broaden access. It's helping us rethink education, and for many of our faculty not by choice, but it took a pandemic for us to think that maybe putting a talking head in front of 200 students and talk for 3 hours in a row may not be the best way to optimize teaching and learning in the 21st century. So what would the post-COVID-19 education, post-COVID-19 universities can look like? So I think it does provide us an opportunity also to really reimagine the world in which the health disparities are not just a way of life, that we can really think about how we can tackle some of the structural inequities that underlie our health disparities.
So there's a question from one of my colleagues about, we talk about disparities within the communities and so on, but at the very beginning, and also towards the end, you mentioned that one of the challenges of our time is the climate change. And here there's been a kind of a conflict between human and the rest, right? And suddenly we see from us staying inside, people are kind of observing what they call nature healing, right? And so, so particularly in the context of developing countries and countries like India, so what about the burden of the population? How do we deal with that in the public sphere, public health sphere, as well as like overall environmental challenges and so on, right? So do you have thoughts about how to deal with the population density and population burden that countries like India and Bangladesh and other countries are facing?
Yeah, no, I think it's definitely a very difficult challenge with a growing population and increasing demand for carbon. But on the other hand, the science is pretty clear that if we don't do something in the next decade, if we're not able to keep climate change below 1.5 degree rise, that we're heading toward that climate catastrophe. So we really have to do something, and this is where I do think that there are potential opportunities for us to really think about how to collaborate, and I also think that university have a very important role to play here. One of the things that I was excited about, and if I were at Shiv Nadar this month, that I was hoping to talk to you and other interested colleagues about, is that when Governor Brown, Jerry Brown, was governor, that every summer he would invite scientists and public policymakers from China to visit Sacramento, and they would have an exchange for several weeks, and they talk about best practices and policies like cap and trade and standards and so forth. Many of the policies have been implemented in California. That's led to a 25% reduction in greenhouse emissions in California in the last decade. And so when Governor Brown retired from being governor, he actually moved his entire team to UC Berkeley, and in September we launched an institute on climate change. And the original plan was that he would continue to do that kind of change with Chinese scientists and politicians, that every summer can bring them to Berkeley and have this kind of continued global kind of dialogue and exchange, and to equip policymakers kind of with the knowledge and tools that they need to enact policy changes to kind of reduce greenhouse emissions in China. And so when I kind of arrived at this theme, I said, why just limit it to China? I think that this type of collaboration is very much needed, and and certainly for the whole Asia Pacific region and Southeast Asia and South Asia, a whole region is very much disproportionately impacted by climate change, including places like Taiwan, Hong Kong, Singapore. Indonesia is already moving its capital, and certainly India is a big part of this as well. And so could we build a regional collaboration whereby we can be working with scientists and policymakers from the entire region, and that global affairs, global politics be what it may. I do think that this is where scientists and academia can play a role in terms of advancing societal population-based and policy changes. And so I still hope that can happen in the post-COVID world, and that in fact I think hopefully post-COVID that COVID is a wake-up call to all of us, that there are certain things that really need to get done before it's too late, but that's kind of the thing that's important. I certainly don't have answers for the tension between the increasing demand as a result of population density, it's a result of population growth, and the policy changes that are needed, the practice changes are needed in those communities and societies to address climate change. But that's also kind of where I do think the ability to come together, the kind of not just transdisciplinary but trans-Pacific, trans-world collaboration is going to truly drive some of the innovations in climate solutions that we all need to see.
Yeah, sure. There are few questions about how to deal with COVID, the current situation and all, but before we go there, there's another question that I would like you to, or comment that I would like you to respond to. So another of my colleagues says that the Global Nutrition Report just released was on the theme of equity in nutrition, right? And it has made a strong plea that nutrition should be made fundamental and integral part of healthcare regimes. And what are your ideas about that? How should governments go about it? And if you would like to respond to that,
yeah, that's music to my ear. Certainly, I think nutrition is certainly the basic building block of good health. And certainly, having spent about 20 years of my career looking at developmental origins of health and disease, and the central role that nutrition plays in maternal and child health, I do think that we need to really figure out how do we make sure that we're providing healthy nutrition for all. I think in many countries, certainly in the United States, nutrition is often an afterthought. I think throughout my I think medical schools are better now, but certainly I remember like in my 4 years of medical school training and in my 4 years of OBGYN training, in those 8 years, I probably had just a handful of lectures on nutrition. And so certainly I think often that just can represent the kind of misdirected priorities that that's reflected in the fact that in the United States, 97% of federal spending is on healthcare, and 3% of federal spending on health is on public health. And so I think that if we truly want to improve population health, especially if we want to advance health equity, that we have to like really think about how do we can reallocate some of those resources and reallocate some of those priorities. Certainly, there are a lot of important things that we need to be doing from a food systems perspective in terms of how we grow food, how we consume food, how we conserve food, how we reduce waste. These are all like big global problems that require not only innovations in practice, but real policy, political, and societal changes. And that's again where I do think that those of us who are in academic leadership have to like really step up to make sure that we're driving those conversations, that we're making sure that we're using science to inform policy, and that we're really making sure that we're advancing policy changes with science, and one of the most important being making sure that nutrition is front and center in any plan going forward to improve population health and health equity.
Thank you. So now let's jump into the current situation, COVID, and a lot of people have questions about that. Particularly, how do we deal with COVID in a country like India, where the healthcare system, the public health system, is very, very, very weak. I mean, one of the conditions, for example, you set for campuses to reopen is like universal testing, right? And in India, the testing has been very, very low. So how do we really deal with it? Do you think, is there any kind of a strategy that you can think of, or you have a reaction to what we are doing in India, for example, or developing countries in general?
Yeah, no, I think, and actually I'll kind of speak to the U.S. situation first. I do think that looking at a lot of different plans across campuses like UCSD, UC San Francisco, Stanford, Harvard, and so forth, that a lot of these plans are actually very heavy on testing and light on everything else. And when you look at plans across the states, in the United States, again, so much focus has been testing and tracing, and very light on systems. But in public health, we think in terms of systems, right? And so like you could test everybody every month, and you're still not going to be able to contain the pandemic if you don't have the right systems in place. And so I do think that resource constrained environments, thinking about how do you build systems, how do you put systems in place for infection control? That's certainly important. How do you put system in place for some amount of testing and contact tracing? And I also think that in resource constrained environment where you can't test everybody, this is where you need smarter strategies. Can we better leverage AI and machine learning to help you instead of testing everybody, is there a smarter way by which you can target testing as part of ongoing surveillance system so that you're able to detect outbreak but I think in also in places that in countries that have like really crushed the epidemic curve, it is really building up their public health system. The places that have really crushed the epidemic curve have they took early action. They set up unified command. They executed a coordinated and science-based strategies. They are able to deploy massive human resources and technological resources, and they provided clear, transparent, and trustworthy communication to the public, and some of which are beyond the limits of your resources, but some of which certainly very much doable. And then I guess the last thing I'll say is certainly COVID-19 has exposed the vulnerabilities of public health systems throughout the United States and throughout the world, and which really needs to be fixed. And so I do think that the question that the premise of the question around the weak public health systems, that's something that the world can no longer afford not to have strong public health systems, but it really requires investing the resources and building up the political will around the world to make sure that we put a public health system in place that all across the world, so that before the next pandemic strikes.
Well, I can do a rapid fire on questions like, how long do you think a vaccine will take? There are a lot of questions about that. Yeah, I mean, I think what it reflects is the anxiety that we live through, right? And in fact, there's a question about that also, right? That how do we, if you have any way to kind of help people here, that how do we live through a pandemic? Do you have any suggestions to that?
Well, first of all, I think the challenge of being a dean is all of a sudden like people expect you to like to be knowledgeable about everything.
Everything, exactly.
And certainly, I have to like confess I am not an expert, infectious disease expert, and so I don't have any better answers than most folks. But I do think from what I've heard from the experts whom I talk to, we're still looking at least somewhere between 12 to 18 months for a vaccine. There's also some real concerns that whether we could actually have a vaccine that works. And certainly we have precedents for that, of not being able to really find an effective vaccine. So I do think while as a world that's really our best solution to this crisis, is to get to an effective vaccine. That it is imperative for us in the next 12, 18 months or longer to like figure out what can we do to really mitigate the tolls, both the tolls on human lives as well as the economic toll on billions of families all across the world. How can we like mitigate, minimize those human tolls caused by the pandemic? And I think public health can play a big role in that. And one thing that, again, I do worry a lot about here in the United States is whether the politicians are kind of listening to the voice of science and the voice of public health.
Yeah, no, that was the reference of at the very beginning of this series. We had an economist from University of Minnesota, and he was also like, "Oh no, no, no! The politicians are not going to hear what the economists have to say." And here we have the same sentiment coming out from you. And in fact, I mean, related to that, let me kind of ask you to reflect on this, at something that you also brought up while speaking, that do you see this, a much more fragmented world emerging out of it, more tribalism, more nationalism, more, clannish world? Or do you think we get back to a far more globalized world where solidarity across nations and people will increase?
Yeah, no, I think there are there are definitely kind of different global pressures, kind of different global forces that are driving both in terms of driving the world in kind of different directions. I think certainly the advances in science and technology, the global economy and so forth have really kind of driven, kind of provide the pressure to drive kind of greater globalization and greater global cooperation. But at the same time, it has created the kind of pains that we saw, and in a way, it was kind of on us to kind of missed kind of those pains in parts of the country and parts of the world that got left behind, which then kind of led to this kind of rise in tribalism, kind of rise in populism and nationalism and so forth. A lot of it just kind of driven by growing social inequality. And so I do think that there are these kind of different forces that are driving kind of the world in different ways. And this is where I think leadership matters. Leadership truly matters. And in the absence of kind of leadership for global cooperation, collaboration, in the absence of leadership that addresses the real issues that we need to tackle, including kind of the global, the rising inequality here in the United States and around the world, that demagoguery is going to take its place. And a lot of the kind of hatred and bigotry and racism and the blaming of the kind of problems that we see in the United States on foreigners, I think it's partly the byproduct of the chronic neglect of the economy for the inequality that's been produced by all of these changes in terms of the globalization and modernization and so forth. And if you don't have like true leadership to actually deal with these problems, then what you have in place is the kind of false demagoguery that's kind of driving the kind of nationalism and tribalism that will keep dividing the world.
You're absolutely right. I think leadership in the post-COVID world would be extremely important, and also partnerships and associations. And I hope all of us here together can come together and work to create a better world. From this crisis, I think there's a lot of opportunity also to shape the world in a way that it was not possible to do earlier on. With that, let's end this today. And I really, again, want to thank you for this very exciting and thoughtful session that we had today. Once again, thank you for also taking time off and being with us. And I hope someday very soon we'll see each other. I missed you when I was in Berkeley, and you missed coming to Shiv University, but I'm sure we'll find a way to see each other and meet each other soon sometime. Yeah.
Yes,
Thank you so much.
very much look forward to that opportunity. And thank you for having me today.
Thank you. And thank you everyone for being with us. And again, I hope you continue to stay safe and hope we get out of this soon and strong. Thank you. Bye.
Take care, everyone.